Assalamu alaikum. This is Dr. Najib Ranganwal. Can everybody see my slide?
Yes, we are
Okay,
good.
great. Okay, thank you very much for coming. This is Dr. Najib Ranganwal. So today we are going to talk about, that's me, and actually Zara Ranginwala, she's my daughter. She will be also attending, presenting a portion of it. We'll go from there. So today we are going to talk about suicide, why the prestigious schools from grades 7 to 12 have a suicide prevention program, and psychiatry perspective. It is a very interesting and very important topic. That's why I like to discuss this topic, why we as a parent need to be aware of it. So let me go into that. So the thing is about before we go into suicide and all those things, we need to know the minor detail about it and go from there. So let me go through that. So in suicide, what we have seen that average about 90 people die per day in America. That's the statistic coming out currently. So it's a very large number of people per day are dying from suicide attempts. And according to World Health Organization, 1 million people every year worldwide die from suicide. So something which has to be taken very seriously, that how many people die and all those things. So 3% of the population from United States make suicide attempts. 13% reported having suicidal thoughts once in a lifetime. That is a huge number, the 13%. So two to three times more common attempts are made in women compared to men, and men are 4 times more likely to complete suicide. So men are more likely to complete suicide compared to women, but so that's something to keep in mind. And among the age group, anybody who's 85 and above have the highest suicide risk. So these are the numbers you have to know why this goes with suicidality. Some other facts about suicide is that Native Americans and European Americans group have the highest suicide rate among the ethnic group. So why ethnic group, when you're looking into it, this is the very important factor you need to keep in mind, especially when the second second on this, I will go into Hispanic females have the highest suicide ideation and plan as compared to Hispanic male. So when we look into the data, we found out that why the Hispanic females have higher suicide rate is because of the ethnic group and where they come from. So people who have come from Mexico and other places, Hispanics, because of their culture growing up, when they come to America, there's a culture conflict. And when there's a conflict, they have found that the female have more conflict than male because of how they're raised. And when they come over here in America, there's more liberal way of living and things like that. So there's a culture clash in that group, and the female have the highest cultural clash, and that leads to highest suicide rate in Hispanic female. That also is also a big finding in that way, that even a different religious group can have the same issues also. So that has very important features. The more important feature I can tell you is that 17% of the teenager in US seriously consider suicide, and that is a huge number. If they look into the data, and they found that the suicide is the second leading cause of death from the age 15 to 24 years of age. And that is very important to know, because before the age of 15, suicide is not the leading cause. It's not even the first 10 leading cause of that. So there's a huge jump from not being the leading cause to a leading cause of that. And so something really changed between before 15 and after 15. And that is something to be aware of it, that what really changes from is in the it's what they have found that after puberty, there's a lot of changes take place in the body of the person, but it significantly changes. What they have seen that the stressors with the kids growing up make a significant effect on them, and they go towards suicide thinking and attempts also. So as a parent, we should be aware of it, that that group has a very high suicide rate, and that death is the second leading cause of death. Among that, 15% have specific plan, 8% attend, and 2% needs medical attention. So, and in the college student, 9% have thought about it or made attempts on it. So that's very important to know that. Um, so going into minor detail about suicide, there is called non-suicidal self-injury, and that is parasuicidal thinking and parasuicidal attempts. So sometimes adolescents try to cut themselves, and that is called non-suicidal self-injury, and this is like 13 to 45%, and that is a number which we need to know that that can lead further to more suicide attempts, and that has to be taken very seriously. So going into psychiatry, what Freud thinks, and that's the easiest way to, there's a lot of theories behind suicide attempts and what's going into the person's mind. Actually, the depressed person express anger at themselves, and instead of people who they betray or abandon them. So it's the basically they fight to themselves, or they actually try to hurt themselves. The anger is expressed towards themselves in a person who is trying to attempt suicide, and that needs to be kept in mind instead of expressing anger on outside. The question comes, how many which condition causes more suicides and all those things, and this the next portion shows that if you look into the mental or medical condition, eating disorder has the highest mortality ratio. Why, when we say mortality ratio, is what we we are talking about the person in a normal who made attempts as compared to the person who has a mental or medical condition compared to that. So they have the eating disorder had the highest mortality ratio. Major depression has 20, bipolar has 15, obsessive compulsive disorder has 11, schizophrenia has 8. But the biggest point to take is the personality disorder. 7% is the mortality ratio. Personality disorder is something a lot of people have it. Means a lot of people don't get treatment for that. So even a normal person has that ability to attempt suicide because of the personality disorder can be. So that should be kept in mind, that these are the features always there in a person who can make attempt to do suicide. Then comes the malignant disorders as well as seizure disorder, which are much lower. So based on these all those numbers, we can say that suicidality can happen to any one of us. Yeah. In psychiatry, we say that anybody has a ability to attempt suicide. So it has to be taken very seriously, that this is a thought which can come to any one of us if we are pushed to the limit. Kids are pushed to the limits, and when it happens, they go into that track. So that should be always kept in mind, that suicidality can happen at any one of us if they are pushed into it. There are a lot of risk factors in suicide. So mental disorder is the most common. 90% is from the mental disorder. The other things which comes to, is the personality disorder, impulsivity and hopelessness. As we talk about gender, age, ethnicity attempts, these increases the likelihood of suicide attempts and died from suicide. Family history, abuses, which is physical, emotional, sexual abuses, and trauma. These are all risk factors. So that really increases the likelihood of a person attempting suicide. They look into the biological factor when they were looking into suicidality in a person, and what they have found that these patients have low serotonin level even if they are not depressed, and that is a good strong finding that not necessary they have to be depressed and low serotonin. People with normal mood who has low serotonin, they have found that they have made suicide attempts. So that is very significant. The other thing is the tryptophan hydroxylase. This is the enzyme that produces serotonin, the L allele genotype. If you have two of these genotypes, they have more likely chances of making an attempt of suicide. So these are the there are a lot of biological factors, but these are the two very important factors to keep in mind. So what happens in suicide? So there is a psychological pain in a person who's going through a suicide thinking or suicide making a suicide attempt. And this is one of the core feature of suicidality and therapeutic strategy to prevent the suicidal ideation. And Schneider proposed in 1998 Likert scale for suicidal pain assessment and its associated suicidal ideation. So this is the psychological pain the person goes through it, and it wraps them up so badly that they make attempt. And it's actually it's called extreme and aversion emotion with unsustainable and unpleasant condition resulting from negative appraisal or deficits of the self. So that's what the exact definition of psychological pain is, and that what they have found that that is a very core feature when they make suicide attempt is the psychological pain. So there are different theories behind that. It's cry for pain model and the escape theory of suicide. So these are a couple of theories they discuss about it, very important theories about suicide. And we try to assess a patient by Columbia Suicide Severity Rating Scale or Suicide Tracking Scale, or we also Sheehan Suicide Tracking. These are the different measurement we can do when we see a patient and see how bad a person has suicidal thoughts and then go from there. So these are the way we assess the patient. Uh, if you want to know regarding what, where in the brain the suicidal thought comes, is in the prefrontal and cingulate cortices are the main organ where a suicidal thoughts come. So these are the this is the prefrontal cortex, and cingulate cortices are over here. So these are the areas which they have found that the person who has suicidal thought lit up over here and then go from there. So these are the area. And so for regarding the treatment, there are a lot of treatment available, like buprenorphine is used, ketamine therapy is used, clonazepam is used, lithium is used, and ECT treatment are used. So these are the medication or medical treatment used to treat somebody who has a significant suicidal thought going on and they're trying to hurt themselves. Of course, the psychotherapy is very, very important, and dialectical behavior therapy is used for patients who have suicidal thoughts. After they stabilize, we do behavior therapy, not when they are completely suicidal, because that's not, they are in a crisis state, and we don't want to engage into this type of therapy. We do different other therapies, but not dialectical behavior therapy. But later on, when they are stabilized, we do dialectical behavior therapy to help them get better. So what the research has shown about suicide, basically the research have shown that suicide prediction is poor, And that is take-home message to all of us who are listening today. The reason why it's so important that when they looked into the data, they found people who have a high risk, the people and the low risk patients. So the people who have a high risk, like mental disorder and all those other medical condition and all those things, they found that they did not die. The numbers who have died from suicide were lesser than the people who are in low risk group. Low risk groups are the common people over here who have no medical conditions, or they don't have undetected psychiatric disorder, or they may have personality disorder. So that's why in psychiatry we say anybody has the potential of making a suicide attempt, because prediction of suicide is very poor. And if you look into the data and how we can get it better, it's very difficult, because if you look into statistics, the positive predictive value is very low in suicide. So that's why we directly ask the person that are they have some thought of hurting themselves or hurting somebody else, and what's going through their mind. That's a very important question which we as a psychiatrist or a physician ask the patient, because that will lead us to what's going in their mind, because the prediction is very poor. Other things which we have found in research, that most suicidal patients communicate their intent. So before they have made intent, most of them communicate with other people. And that is one of the good reason why a lot of um, uh, physician needs to ask this question. Any thought when they look depressed or they have said something that raised red flag, we should ask directly this question, that are they have thoughts of hurting themselves or hurting somebody else, and things like that. So we can know or proceed in that direction. Most suicidal patients are not necessarily seeking the end of life, but they want to relieve from psychological pain. So this psychological pain which the person is having thought is so significant that they may attempt suicide because they want to relieve them out. So for relief factor, they may attempt suicide to get out of it. And most of them, it's basically because of hopelessness and helplessness. Hopelessness is very, very important. So they are hopeless and they want escape phenomena or escape response out of this situation. And this is the most way they approach by making a suicide attempt. Most suicidal patients have identifiable or treatable psychological social problems. And this is always, we have found in research that this is very important, that they have identified issues going on and that needs to be addressed. So the question comes, how the school is want to address this issue, because as we have discussed that between the age of 15 to 29, that's the second leading cause of that. So in that way, the school addressed by different ways. One of the way is they have a hope squad in school, and the hope squad from the grade 7 to 12, this is a peer group where the students are selected from their peer, and they try to find people, or when they see their ears and eyes for other people, if they see they have not doing well, or they feel sad, depressed, they communicate with them and try to figure out what's going on. And if they mention about any destructive thoughts or anything, these students first comfort them and then inform the counselors and other with to get help. So basically, they are eyes and ears for the school to pick up anybody who are thinking in the direction of hurting themselves. So the Hope program started in 2005 in Texas, and Nowadays, there are more than 35 states who have HOPE program, and basically what they have found that initially there were one student dying per year in a lot of schools here in different states, and that was a significant loss. So they started this HOPE program to because out of 10 students, eight students were able to get better because the students talk to other students if they're not feeling well or they have any plan of hurting themselves or hurting somebody else. So with this program, they were able to achieve zero suicide rate in this school, and that was going on for last 10 years to my recollection that for last 10 years nobody has made a suicide successful, or nobody has died from suicide. Some of the students have gone to the hospital but not from the suicide, but because they were depressed. So HOPE program is very successful in school, and most of the good schools have this program, and it's very important for students to inform each other to help themselves and help other to go from there. Unfortunately, Zara is a little bit sick right now today with a sore throat, so she will not be able to present on the Hope Squad, but we will go from there. I think so. I have her recording, but basically, that's what she wanted to talk briefly about Hope Squad, that how they help. But this is what the basic information is. That's all I need to discuss. If anybody has any question regarding suicide, I'm happy to discuss.
Thank you, Brother Najib. It's open to the floor to make comments or any suggestions or anything. Or questions, please. Brother Najib, can you tell us a little bit about if you know the Hope Squad, like how is the function? Like they are just students who are within the class that
So how its Hope Squad works is that the peers, the students, the fellow student elect them, or the teacher elect them based on their demeanors and the behavior, that they feel like this student has a good ability to empathize, have compassion, a caring person, and they feel like they will be very helpful to identify any other students who may be under stress, and that's how they are selected. So it's always selected from other students and teachers, and basically they are eyes and ears for the school to figure out if somebody having thoughts or having feeling sad and depressed and it's going on for a while. So then the counselor get involved in it. First they try to get more information from the students so they can help them, and then if they feel like this person needs definitely help, then they encourage the student to go to a counselor, or if they decide not to, then they inform the counselor that this is going on with this student, so if they can help them. So basically, they trying to avoid any suicidal thoughts which can come in a student under stress, and basically that's why the school is very successful. That there was no suicides. Successful. What we say is suicide. Death from suicide has never did not happen in the last 10 years. Hopefully, I answer your question.
Yes, you did. Thank you. Thank you. Sister Amani, do you have anything to add or share with us, or how things work in your school system?
Good morning. Assalamu alaikum. Great presentation, Dr. Najib, as always. Actually, everything like was uh, not from Dr. Najib's perspective because that's not like the expert perspective, but from like the school now, many schools are taking preventive measures, and because like Dr. Najib mentioned in the presentation, the age group, sometimes it depends also on the economic needs and other and social status of that person. But we noticed, and just locally, I'm talking about the training that we went to this year, we have noticed that the ways and of like the students use to express their emotions are now different. They use social media. They don't have that peer-to-peer connection. They don't have personal connections with someone. So now everything is heavily dependent on the social media. And that's why we now have anonymous hotlines for each school that the student can anonymously go ahead and say anything. It could be about how they feel. It could be about someone else that they think they are in danger. And many schools are adopting this program. And it's honestly effective. So far, we had three. It's not just about suicide. One of them was about a student who noticed one of his friends had written some notes. And one teacher actually also anonymously wrote about a student just because maybe she doesn't want to be involved with CPS and things like that. But I just wanted to mention that social media, if we can watch, I'm not saying like exactly everything that kids do on social media, but some parent supervision, it's really highly recommended on what they write and what they receive as well. Thank you.
Thank you, Sister Amani. Sister Rabab, if you can add anything as well, because you were an administrator in higher education. So if there's anything that you could add to this as well. Brother Naveed, you're a primary care physician. Also, if you have a chance to talk to us from your experience, if you're available. I know you're probably driving.
Yes, I'm driving, but I mean, as Dr. Najib mentioned, that we do try to ask the question about if their patients are depressed, that if they have any suicidal thoughts or if they have thoughts about hurting themselves or anyone else, and obviously, if you see some red flags, then you need to intervene. But I think that as Dr. Najib mentioned, it cannot be predicted. I mean, I know there are some patients who are in hospital, especially if they are depressed because they are sick, and they sometimes say, "I want to kill myself." I mean, and then obviously that raises a red flag, and then uh, all the people, including psychiatrists, get involved. But it's good to be proactive. I am not denying that, but I mean, again, that people sometimes say things, but they don't act on that, and it's at that time they are so depressed, they are so in pain, or all those things that they do mention that they want to kill themselves. But sometimes they don't have a plan; they just say that. So that's why I'm trying to ask Dr. Najib that I mean, sometimes they will say that, "Oh, I'm so miserable, I want to kill myself." What should be the response at that time?
That's an excellent question. So there are two types of suicidal. One group is impulsive, and other group is make plan. So there are two different types what they have found. So basically what we have seen in psychiatry, that we try to assess them very thoroughly, and we take it very seriously when somebody has even said, I want to hurt myself, or I'm thinking in that direction, or life is very miserable and there's no point of living. That is very important to pursue, because we have seen in a lot of people that when we intervene and like to know about it, we find that some of them really want to hurt themselves. Basically, if you, but the thought just came to the mind and they just open up. So it's very important to go and search and try to find out whether they really have intention or what's going on in their family life and all those things, and where it's going to happen. Because the best prevention of suicide is to know ahead of time. What we say that is just suicide is just like throwing the snowball from the top of the mountain. So as the snowball keeps rolling down further, it gets bigger and bigger. So suicidal thought is just like that same thing. If you are having suicidal thought, it can get worse and worse as the time goes on. And if you don't get help, later on, you are not able to come out of it. So the best way to stop this whole process is to ask the question as early as possible. So the predictions are very poor for suicide, but we need to look into, and that's why we call the psychiatrists at that time, because they are more able to obtain information from the patient and assess them, that did they just mean it, or they just saying it because they are frustrated, and then we go from there onwards. So there are different groups. Like if you look into the Hispanics, which we have found out that Hispanic never, most of the time don't admit they are depressed, and that is also very significant that some ethnic groups, they decline to be sad because it's not in their culture. And I had one patient in the past which made a attempt from 5 story and crushed his all most of his bones, and it was in surgical unit. Of course, psychiatry was involved in it. Till for 3 weeks, he declined that he was not depressed, but he did that. And then, of course, after a lot of intervention, he opened up, and basically because of the ethnicity, they don't accept depression is part of their life, and and then the psychiatrist really finds out that there is a issue behind that, and then they treat them. So it's very, very important to ask, and you can call the psychiatrist so they can obtain more information and go from there, because you don't want to lose a patient, which has happened a couple of times in a hospital setting, that highest number of suicide attempts are made when they are discharged from hospital. And this is the time when they have enough energy to coming out of depression, and they go into the suicidal behavior and make attempts. So it's goes back to the physician who has discharging them, that they didn't look into that. That person was thinking about that. So it's very important to ask that question and document that in your note, that they were not suicidal at the time of discharge or at the time when they saw the patient. Hopefully, I answer your question.
Dr. Najib,
Yeah, go ahead.
I have a question. So you said that last 10 years there was no suicide in Kerala district or anywhere in
Where the whole programs were. So they don't have the data in the last couple of years since COVID, but before that they have found that the places where they were having the Hope Squad, the suicide, then there was zero number of the student who made suicidal who died from suicide. There were none.
Okay, because I little bit doubted because I know in last 6 months in Keller School District, I'm not sure if it's part of Hope or no, there was a suicide.
Completed suicide means the person died from suicide?
Yes, he died
Okay.
from suicide. And there's a funny story, but in the middle school, our middle school, there was kid, these kids, they talk so carelessly sometimes, the way Dr. Siddiqui said that sometimes they talk, but they don't mean it. They say things like, I'm miserable, I want to kill myself, sort of things. So the kid said that, something like that, in his group, and someone reported it to school, and whole school was like on their feet, and mom has to actually put a post on school page and on mom's group that my son is perfectly fine, he's just stupid. He said something that I did not know why he said that, and he's perfectly safe and fine, he has no problem.
Yeah,
So sometimes it happens that kids say things that they don't even think what they are saying.
correct, and that's true. So we don't have data since COVID and a couple of years before that, but uh, the other data which was shown to our group in the Hope Squad, that they didn't had any death from suicide in the last 10 years, but the data is missing for the last couple of years. So I'm not sure about what this was included in that year or not, but that's what happened. But we need to take anybody who make gesture or say something about suicide to take it seriously, and that is significantly important. And why it's so important that if they made attempt and do things that can be prevented. So that is one thing we need to be aware of it.
Yeah, I got it. It could be serious too. You cannot ignore it. The saying that they're just saying it.
So that begs the question, Dr. Najib, that in our day-to-day life, I mean, we're not talking about school, but in our day-to-day life, if we come across a comment or a post or whatever, and about a person who we know has made that comment, what is the legal and ethical responsibility? How you proceed? Who do you call? Who do you report to so that can be taken care of?
That's a good one. Okay. So, as a physician, you are liable once you start talking to the patient, correct? So that become a legal bounding, correct? Um, so basically, if the patient says to you, you need to get help as much as possible. You cannot so how it works is that you listen to the patient very well, and then encourage them to go ahead to get help, either go to the ER or the primary care physician or the psychiatrist to get help. And so you advocate everything, and if it's your patient, you have to document that, correct? If you feel like they make attempt or they are likely, so you make everything possible that they may have to go to see a physician or something like that, because because that's your patient. Um, uh, when they go to the hospital or they go to the ER, the physician sees that. The physician try to admit them if they feel like they have significant made attempt or they are going in that direction and they need hospitalization. The patient can decline at that time, and that become a more complicated issue, because then the hospitalization without the consent, which is involuntary hospitalization, can also take place. If the physician feel that their life is at risk, at that time they do that, and there's a whole process of doing it, which a physician do it. So yes, as a patient you have to, if it's not your patient, then after listening to them you have to advocate to go and see the physician, or if they are young kids, then they should discuss with their parents because a lot of times the parents is not aware of it, that what their kids are doing or what they're saying. A kid saying that I'm suicidal is not is a very serious word, and we take it very seriously. So you and try to find out what's going in their life. It's just they are saying because they heard about it, or they mean it, and that can be only assessed if you spend time and find out what's going on and try to ask them to get help, because people, normal person, don't say that I'm suicidal or I'm having a suicidal thought. So because the prediction of suicide is very low, so we don't want to sit on it that the person is saying, and not to inquire more information of it. Hopefully I answer your question. I know it's very difficult to go forward, but that's the best help we can do, is prevent suicide.
Thank you, Brother Najib. Sister Rabab, if you're still with us, if you can tell us about initiatives or works in the higher education.
Yes, I was with you, and I was actually talking to myself, thinking I didn't know I was muted. I'm sorry. I think what Sister Amani said about the program they are doing is something really, really good. And I know in some higher education institutions now, they are having special counselors, and yes, students can speak to the counselors in privacy, and but I think the thing that we need to pay more attention to is the parental role in all of this, because the kids usually go through some kind of changes, whether it's sleeping, eating, staying in the room, and so forth. And I really think it should start with the home, and the parents noticing the differences and changes in the kids and what they're going through. And most of the time, from what I read, that most of the suicidal is in kids or teenagers, usually due to relationships, that didn't go well, or something in that nature. So you find that mostly in the high school and college and so forth. So I think it's special counseling in the schools and colleges, and the parents at home, and what is happening around is the first and most important part of avoiding or getting to that level of suicidal.
I totally agree with your plan, and that's parents needs to spend time with their kids. The Hope Squad also feels strongly that the students are spending a significant amount of time at school. So, and they have a lot of friends over there who they open up and talk. So then that is another avenue to help them. But the parents are the utmost important part of the family to help the person.
And sometimes it's also the role of the parents is to watch the kind of associations and friendship that the kids have with whom. And I think it's really important to know who our kids are associating with.
I agree on that part, Sister Rabab. Yes. But then sometimes the parents, I mean, the kids feel parents are censoring them, or parents are, you know, don't have trust in them and their selection, all of that. But my parents did know who my friends were, and they, you know, they sometimes even told me don't be friends with this person or that person, things like that. You know, maybe I wasn't very happy at the time, but
Mhm.
I know now what that means, you know, being a parent. And they
Mhm.
didn't threaten.
I think it's the way we handle it and the way we do it too. It's really important. It's not like, okay, I don't want you to speak to this a kid, and I don't want you to speak to this, to that, and I don't want you to speak to that person. I think it's the way we do it is very important.
Yes, I agree with that. All right. Anybody has questions, comments, or anything? All right. Brother Najib, thank you so much for this very nice presentation, and for all of you for being here on Sunday morning. May Allah subhanahu wa ta'ala reward all of you. There's nothing, I will make our dua. سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين. وصلي الله وسلم وبارك على سيدنا محمد وعلى آله وصحبه أجمعين. جزاكم الله خيرا. إن شاء الله we will continue to meet every Sunday morning. And inshallah we'll see you next week. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum, and thank you for everybody to join in, and that was very helpful.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.